Today, we're going to be hearing from Sarah Parker. Sarah Parker is an experienced pediatric speech pathologist who works with children with oral motor and feeding dysfunction. Sarah has devoted the past 25 plus years working with infants and children with complex medical diagnoses to help them develop their oral motor feeding abilities, as well as early speech, language, and communication skills. Sarah enjoys working with the families and caregivers, as well as the team of doctors, therapists, nursing, and nutrition to ensure proper nutrition and growth needs are met for each child as they develop their oral motor skills. Sarah also is the proud parent of two grown daughters, both born with complex medical feeding issues. Her experiences as a parent helped change her professional interactions with other families after living with her own hard to feed and grow children. So with that, I'd love to go ahead and pass it on with Sarah. Sarah, welcome.
Hello, hi, how are you?
Good.
Good.
Your slides up here.
Okay, good. Okay, so everybody can hear me, right? We're all good?
Yeah.
Okay, so you tell me when I'm having issues then. Okay. Hi, everybody. I'm Sarah Parker. I am from, Monrovia, Indiana, which is Indianapolis, Indiana, to the rest of the world. I have been a feeding specialist with little kids. I've worked in the hospital setting, first step setting, clinic setting. I've done a wide variety of things with kids, working on their oral motor skills and helping their families. This first slide here has my contact information, my email, and my phone number. So if you have any other questions afterwards, then you can always find me and we can chit chat from there. As Sarah mentioned, Sarah Peden, I have two daughters. Both are born with Pierre-Robin sequence. And again, not the world of Prader-Willi, but it is, we had lots of medical issues. My first one, the one with the sunglasses here, she's at Rose Hulman studying now, doing very well, but she had small jaw, cleft palate, obstructive apnea, was on oxygen, was on a feeding tube. I don't even know how many surgeries we had. And she had hearing loss now from her deficit. So we're working with at college now and when living with hearing loss as an adult and working on that. And my other one is Heather, and she's a junior right now in high school, doing well. And she also had that. She was not as complicated as our first one, but of course we learned a lot from our first one that we did differently with our second one. So she benefited from part of that. So anyway, so again, not totally everything with that, but once you have a child that's medically fragile, it changes everything in your world. And you guys are learning that and know that. So, all right, so let's talk about a few things here. We need to know about swallow studies because that's one of the first things that gets little kids caught up in the medical system. With the newborn, if you guys are still in the hospital, a lot of times they'll do what we call swallow study. Different places call it different things. But we look at swallow studies. We're going to look at oral motor development. We're going to look at how they develop feeding stuff, and then the special dietary needs that we have to accommodate when you're looking at kids that we want to stay on high calorie, but not a lot of carbs, and working on things to help them grow and work with that. All right, first thing, swallow studies. So, okay, so this is hard to do when there's no real feedback. So you guys, I don't know. Oh, we are with that. Okay. There are lots of different names for it at different hospitals. We at my hospital always call it a modified barium swallow, but it's also known as an oral pharyngeal study, video fluoroscopy study, or VFSS, video radiographic, video fluorographic swallow study, 3 phases. They even call it sometimes a cookie study. And what that is if you can see in the top picture here, the little one is usually in a, we call that a tumble form there, but they're different feeder seats. Sometimes they will let you hold them. It depends on if they have a C-arm that will go around for the child, but sometimes you can hold them on there and do side lying in different feeding positions to help with that to see. And then the second picture here, it's probably a little hard to see just off track, but right in the middle is where the jawline is, and then you can see the back part there. And we watch how the food comes in. They put barium in it, and they watch how that swallows, and we look to see if they're aspirating or not. And almost all little babies born with low tone aspirate. So both my girls were aspirators as well. So then we have to start looking at how to thicken it. Sometimes they make them NPO where they can't have anything by mouth. And then that affects all the development and how they learn the motor planning and development with that. So over here on the next slide, things that sometimes are, there we go, thank you. So what we have is usually silent aspiration, which means the baby didn't cough or indicate that, which is not uncommon for little babies that aspirate. But sometimes you had no idea that the baby was having troubles feeding because she never or he never coughed to tell us what was going on with that. Sometimes they do choke or they gag, especially when eating. If they gag a lot, they might throw up. A lot of kids will do that, especially if they're on tube feedings. Hard thing is in the beginning, these little kiddos are hard to gain and hard to grow. And that's a hard thing. We have to keep up on that. So we have to make sure that we're getting enough calories in. If they're vomiting a lot, if there are ways to help with that. We always also listen if they have a wet, gurgly voice. Sometimes when you have low tone, you have the secretions are hard to manage because when you eat or drink, we make more saliva so that we can chew and swallow it. And sometimes that adds to it. So we have a lot of wet, gurgly sounds with it. So sometimes kids sound worse than they actually are. And then sometimes when they sound that bad, they actually are having troubles. What we run into also is sometimes the kids will refuse to eat or take anything much by mouth. So they might feed well, or they might take 2 ounces really well, and then they stop feeding or taking the bottle by mouth. And again, that's hard to gain weight in the beginning. When you're first born, 1 to 2 ounces every couple hours is pretty typical. However, if you only take 1 to 2 ounces and you stop feeding and you keep getting older, you aren't keeping up with the calorie needs that you need. So we have to watch for that. Sleep habits can be another issue. Sometimes they wake up a lot. Sometimes if they're not getting their calories, they're hungry, and those are problems with that. And then if they reflux, a lot of times apnea can be issues and they're just having breathing issues. It's easy to catch pneumonia or have irritation in your lungs with this, which can also be another factor. And then any kind of other neuromotor involvement. So if you're low tone, you might have respiratory issues. If you have any prematurity, sometimes you have respiratory issues. Low tone, high tone, you have delayed oral motor skills because of low tone, and then posture control. So sometimes when you have low tone, you're kind of a floppy baby and they're hard to hold. So you have to swaddle them a little bit more. Sometimes swaddling is really important to help with the feeding and help them move along with that. All right, next slide here. This is just a little picture to show there's a couple phases of swallowing with that. So the first part is the oral when you actually get it in. This is a picture of a spoon feeding with that. But if you have the bottle in the mouth and how they're swallowing it, you have to get the food or the bolus and the drink into the mouth, and then you have to move it back to the back of your throat, and then you have to coordinate it at the back of your throat, right where the airway is and the esophagus opening to the stomach. They're both next to each other. So if you aren't very good and you can't control things and get your airway to close the way it needs to, then you risk the run of aspirating. And then we want to make sure it goes all the way down the esophagus, down to the stomach. And you can even still have with low tone where you have some of the reflux concerns where it goes up and down in your esophagus, and you can still have a risk for aspirating from pooling or things not moving, the drink or the food not moving down to the back of the throat to swallow. So things that you will hear when you have a swallow study is aspiration is a concern. And that means that food or liquid is going directly into the lungs when they are eating or drinking with that. And when that happens, they start talking to you about NG tubes and feeding tubes, and because they have to protect the airway and the lungs so that they don't get filled with liquids. Penetration means that, so when I talked about there's protection, there's like a little umbrella, the epiglottis covers up over the vocal or for the airway. And so if you have penetration, it means it's sneaking in under that umbrella area before it gets closed and but it comes back out. The concern is that if you have too much penetration where it's going in and sneaking in there, if you have more than 50%, that means you're most likely probably aspirating at other times as well. So you may pass a study, but have lots of penetration. We still may need to thicken what we're giving them by mouth or use the tube a little bit more so that we can help them so they don't aspirate with that. How they control the food and the food or the formula, breast milk, whatever. When I say formula, it's whatever you're offering them with that. Breast milk and formula are typically the first things with that. So the issue is how they control it in the mouth and if it's dropping back too fast. So it might be the flow of a nipple. Nowadays, there's all kinds of nipples and nipple flows, and you can get slow, medium, fast. You can get a preemie nipple, you can get an ultra preemie, and it's hard to understand all of those. You really just need a basic preemie type of nipple or standard nipple that they can still suck on and get the liquid out and be able to swallow it down. But we can sometimes help them. If we have to thicken it, we might need a little faster nipple so that they can get the thickened liquid out. It's hard when you have low tone to suck and maintain all of that, and those are the things we look for. You okay? And then you have to make sure that you're getting enough to assess that. So sometimes at some places, I worked at our pediatric hospital here in town, one of them, And we would always make sure that we got at least a decent feeding. So we would give them the bottle, let them suck a little bit, and then we would turn the radiation off and let them suck a little bit more. And then we would turn it back on, because sometimes if you only get 3 or 4 sips and swallows on a study with the radiation, they might look like they're doing fine, but they're actually still having troubles. And fatigue can be a factor. So if they're only getting 5 cc's, but they actually take a 2-ounce bottle, then we really need to know how well they're tolerating that, and if fatigue is a factor with swallowing to keep their airway safe. This is just general information for you to have on the next slide here about barium and the different textures that we have. There's usually a powder that they use, and that's typically what they mix in with the breast milk and the formula. And they have paste that they can also mix in with some of the foods, the baby food or purees that they might be looking at. Liquid barium also can mix in with that, but that's already a little bit thicker. Breast milk itself is considered an ultra thin liquid, and the regular format typically is considered thin liquid. Oops, can you help me, Michael? So if you add it and you change the viscosity of it too much, you have to be careful with that to make sure that they are that we're getting the right assessment with it. So if they're having troubles with breast milk, then we might need to figure out something to put in to thicken it so they can tolerate that. And then same with the formulas. Powder put in there, the paste, like I said, if you're using food, we can mix that in. And then solids. There are some pre-made barium stuff, and some places are using more of those now with all the COVID restrictions and what kind of foods can be offered with that. But that would be if your kiddo was a little bit older, maybe a year or 2 years, if they would have something soft, chewy, and work on that. Alrighty. Oh, here we go. I went through most of this. Sorry, I apologize here. Ultra thin liquids, breast milk, water, juice, or soft drinks. Thin liquids are milk and most formulas. Semi-thick would be if we add a 1/2 tablespoon of infant cereal. They typically use oatmeal baby cereal now. They used to use rice, but there was all the concern with the arsenic in it and the large levels that kids were getting when they had a lot of thickened liquids. And so nectar thick would be 1 tablespoon of infant cereal to 2 ounces of a thin liquid, and honey is 1 tablespoon to 1 ounce. We can also use purees, which is sometimes what we do with the kiddos that we're worried about extra calories. I've had some kiddos that they've had so much cereal in their bottle in order to prevent getting a G-tube. However, then that's a lot of extra calories. So we have to be careful of those extra calories that they're getting. So a lot of times we will use some of the baby foods, like the squash is low calorie. The vegetable ones typically are pretty low calorie. So a tablespoon of cereal is usually about 25 calories. And when you add that in, so if you're making up a 6-ounce bottle, you think of that, you're putting in 3 tablespoons of that, you've added an extra 75, maybe 100 calories on that. If we use some of the baby food, which is a full 4-ounce container is only 20 calories, then we get better. We can still thicken it and not have too much problem with that. So here's some of those things. So the difference with you are one slide ahead of me. Thank you. There you go. Sorry. Okay. So purees. I don't know if anybody knows about this. If you already have kids, you probably know about it, but if not, stage 1 purees are 75% water, and stage 2 are about 50% water, except for like the bananas and the meats. Those tend to be thicker anyway. So when you're getting baby foods and we're adding stuff to thicken in, we usually want to use a stage 2 baby food. So that way it's not so much water in there because we're trying to thicken it is what we're trying to do. And the more we have with that, the less calories it will help us with. Thick, smooth purees are like the baby food bananas. Puddings can mix in with some kids, and meat puree, sometimes we'll use those, but those are thicker. And then a lumpy texture is considered, they've got 2.5 and stage 3 baby foods. An adult applesauce, a regular applesauce that we buy at the store would be a lumpy because it has some little textures in it and doing that. So those are all things that we can use for purees and working with that. Mechanical soft here. That would be any of our canned or cooked fruits or vegetables, frozen vegetables with that, fresh stuff with that. If you mash it up, we can do that. Pastas and grains fit in there, and those are also a soft chewy. That means you have to chew like 3 to 5 times in order to break it down and get it going with that. A chicken nugget, a fish stick, any other fish with that, egg salad, fries, veggie tots, the little vegetable tots that they have now that are out there. Those are all part of that soft, chewy. Pancakes, fat bombs. Sometimes we'll use some of these with the kiddos when we're working on increased fats and lower calories for some of the kids. And breads would fall under that category too. Puffs are a great food. We use these a lot now. There are the basic Gerber puffs like that, or the, the little ones are like A-shaped and star-shaped with all of those. I don't typically use those because those are really truly empty calories. But there are some other puffs that are out there. So like there's veggie straws that I use, you can see here, Cheeto puffs and natural ones. Benito's has some puffs like that, and then the hip peas are all chickpea with that. So some of these are vegan products. They don't have a lot of extra additives to it. But those, we work on that so you can place it in the right and left sides of the mouth and use their gums, or if they're starting to teeth, to start crunching on that. And that's how we work on developing tongue lateralization. But this is a texture that we can check with kids because a lot of people feed these to the kids with that. All right, hard solids are the next one here. So these are more solid foods, typically stuff that we don't always offer our kids, graham crackers, the puffs, popcorn can fit in there. Regular Cheetos, Ritz crackers, there's just a little bit more texture. They do dissolve still pretty easily, but it's a different texture. Chewy means we have to chew more than 5 times. So that's where our other proteins come in that we use. So like a fruit chewer, fruit leather, sometimes we'll use these. Cheese and meats and sandwiches, or we have to chew more than 5 times to get it. And then hard foods are stuff that little kids do not use that, but it is something that if you're 3 and older that you might use. So sometimes with our kids, we can do crushed nuts when we can mix stuff in, as long as they're fine allergy-wise and all that. But nuts by themselves are harder to chew and they're a choke hazard with that. Well as cookies and chips and that stuff. So again, these aren't a lot of foods that we offer our kids, but those are foods that we look at for textures, and we can find textures in different foods that we look at for the swallow study so we can check to see how they're doing. All right, multi-texture means that it's a combination. So chicken noodle soup with the liquid in there, meat with the gravy, cookies with nuts. So that's another solid that would be mixed in there. A fruit cup that has syrup in it, those are liquids. So what sometimes happens is that we're working on one food item and the other food item is in your mouth as well. And then you have to be careful because that's harder to chew or harder to control. And you can actually choke and have problems with textures like this. So sometimes in the beginning, we'll drain stuff off. So we might have a can of chicken noodle soup, drain off the gravy or the chicken broth from there, and then just use the food from there because there's flavors with that. Same with cereal. Sometimes a regular Cheerio, a lot of people will do Cheerios with kids, but actually that's kind of a choke hazard you have to be careful with. But you could soak it with a little bit of milk, drain the milk off and let them have the cereal and work with that. All right, we talked about some of the thickening agents with that. So I put down what the basic nectar consistency is here on a swallow study, which is 1 tablespoon of a baby cereal to 2 ounces of a thin liquid. Stage 2 baby foods, a nectar consistency is 5 tablespoons to 2 ounces of puree that we can mix in. Like I said, we usually use the vegetables with our kiddos, so when we're worried about extra calories filling in. If they're over a year, there are other, you can use more purees, yogurt. Certainly we can start adding some of the Greek yogurts in and the other yogurts to thicken. There are some powder thickeners and gel thickeners that are out there. None of them are all really recommended for kids of a year. Basically over 3 is where they recommend for anything gel based. The Simply Thick, there's some other products out there that are similar to that. Gerber has a product too. But that's something that sometimes the swallow studies will recommend and do all of that. But you would have a swallow study that would tell you if you needed to use this or not. Typically what they ask you to bring to a swallow study, they'll ask utensils that the baby might be using at home or your child might be using at home. Usually they have some basic, but sometimes they have like just a big regular plastic spoon because it's disposable and you wouldn't use that to feed a little baby. So I always say you should probably take a few spoons with you to work with that. The flatter ones they are the better. If they've got a big bowl on it or a big scoop on it, it's hard for a little baby to get their lips around it to suck it out from there. Like I said, there's different kinds of bottles and nipple. I've had families walk in with just full paper bags of different types of bottles and nipples that they've all tried to use to help with their baby. So we usually try to just stick with 1 or 2 basic ones. There's not one that's a magic bottle that works for everybody. It's really depends on which kid and how their oral motor skills are. But basically, we usually almost always just try to stick with a standard nipple shape where that is and going from there. Okay. Let's see. Watch for liquids falling from the mouth. Yes. And we want them to be safe. No, you're good. You're fine with that. Radiographic studies. So you want to see where they are. So if you take a 1-year-old in and they only look at a bottle, you should also be looking at a cup of some kind because your 1-year-old is growing older and you want to see if a cup might help them do better. With a bottle, the liquid is straight shot into the back of the throat and swallow it down. With a cup, or a straw cup. I have a picture of one here, the Rubbermaid little cup that I use. There's other free flow straw cups that are out there, but this is one that I always start with low tone babies. Is that then you can still thicken it if you need to, give a little bit of a squeeze, but you have the drink right in the front of the mouth, and then you have to learn to transfer it back. And that's one of the skills we have to teach our kiddos. All right, so they give us feeding suggestion, therapy recommendations. They should sometimes, in Indiana, our early intervention program is called First Steps. Sometimes kids start getting referred to First Steps early, and they recommend for feeding specialists to help you out. I'm a speech therapist, and this is what we do with that. In some areas, occupational therapists are recommended, but I'm a speech therapist, so I say speech therapists should be doing it, just so that you know. Other teams with follow-up, sometimes then they start talking to you. So you might have had a swallow study in the very beginning when they were just first born, literally just finding out and getting diagnoses, and they're aspirating everything. So they put the tube in, they might let you do 5 or 10 ml by mouth and practice with that and put the rest in through the NG tube typically. And then they're going to check you again at 3 months or 4 months of age. And so you might need a plan to follow up with that and work with their skills and see how they're doing. Of course, sometimes these kiddos are on oxygen. You have to work around that. Nutrition guidelines for weight and growth concerns. It's really hard to find a decent dietitian who knows about working with babies that have the dietary restrictions that we want. So we have to pay attention to that sometimes and make sure that that's working. How you hold them, sometimes side lying works, sometimes holding them upright works better, different utensils, different feeding. Kids need to be fed if they're, once you get on a tube feeding schedule, you'll understand. So like every 3 hours, pretty much no matter what, if the baby's throwing up, you still have to kind of work around that and do that. And then sometimes if they aren't allowed anything by mouth, sometimes they can still practice with the pacifier, and you might dip that in formula or breast milk and let them do that. But that's non-nutritive, and that's just to make sure that they don't get aversive to nothing by mouth. If you go 3 or 4 months and you don't have anything at all by mouth, sometimes it's harder to work with those kids to get them to take stuff by mouth. So in general, with swallow studies, if it's NPO, that means nothing by mouth. They'll talk to you about an NG tube. They may say a G tube right away, but a lot of times with babies, they'll do an NG tube for a little bit of a time. And then they want to see if they can have any taste. Like I said, that 15 ml by mouth to practice with that, or maybe a little taste of puree. Sometimes if they're not through their mouth, we might start purees a little bit earlier to give them oral motor practice. Quality of life, of an NG tube. In our case, our daughter was probably about 4 months old. She had an NG tube, and she vomited all the time. She vomited the stupid NG tube out several times. I mean, my husband and I were crying more than she was when we were both holding her down, getting it back in. And it was not a fun thing. We couldn't handle it anymore. So we ended up going with the G tube when she was younger. But that's just, you have to figure out quality of life and what you guys can do and what we had to take care of stuff. It also impacts potentially daycare services and providers. So if you're a working family and you need to be able to get back to work, a lot of places won't take a baby with an NG because it can slip easily and pull out easily, which is true. And so a G tube is actually safer in the long run with that. But again, if you don't want to do a surgery, if you have a baby with low tone that has muscle issues, that you need to be careful of. Anyway, those are big life pictures that you need to talk about and go from there. But typically what we want to do is, okay, they need a feeding tube possibly, then we want to do a little bit by mouth and keep the practice going and working on that, and that's where therapy kicks in. All right, NG and G tubes, we've got that. Oral motor feeding. So here we go. Feeding is about breathing, just so that you know. If you can't breathe, you can't feed. It's no different than holding your breath and trying to swim across a full pool. You have to breathe. So you come up and you have to breathe. So that's what makes it harder for you to do that. So if you can't coordinate it and you have troubles breathing, then that increases your risk for choking. And kids with low tone fall under this category with that. Also, if they're born any earlier, sometimes they're born a little bit earlier because of these things, and that can also be a factor with that. The pacifier, you typically want to match the pacifier as what your bottle is that you're using. And our goal is to break up the obligatory, just kind of suck pattern, because they aren't breathing when they do that. And so we pace them sometimes where you allow them 3 to 5 sucks on the nipple. And then so if you're holding them and they're lying down and they're doing 3 to 5, you count 1, 2, 3, 4, 5, then you kind of sit them up and let the formula or milk it out of the nipple a couple seconds. That way that allows them to swallow. Then you kind of let them lay back and you can do that. So this is a very easy process that we can practice with and teach them. And sometimes I think it takes longer, but actually it's teaching them to kind of swim across the pool. So you do 2 or 3 breaststrokes when you're swimming, and then you stop and you breathe, then you do a couple more breaststrokes, then you stop and breathe, and that's what we're teaching the kiddos to do this. And as they get more efficient, they typically start pacing themselves. So breathing and pacing is very, very important when you're working with babies. Things to know about nipples. There are hundreds of them. You can walk into a bye-bye baby right now, and I actually don't even know all the nipples that are available because it changes so much. The goal of it is for your tongue to be able to cup around the nipple and get your sides up on it and cup, and then you kind of pump and come back and pump and come back and pull it back. So that's what you really want with that. There are nipples that are flatter, like a Nook nipple and others like that. Sometimes those are harder for our kids because they keep their tongue so flat that they just are kind of pumping on it and they aren't getting the suction out that we want them to work on. There's a difference between silicone versus coming to the plastic ones. The silicone ones are a little bit more sturdy, but if we have to cut them or do anything to them, it changes the strength of them and the viscosity of the plastic too. So we have to be careful about that. Straight versus orthodontic, that's the straight nipple versus like a Nook nipple or a MAM nipple. The flow rates, we have to check on that. We really don't need to increase the flow. You have to be careful because sometimes we get kids, they can stay on a level 1 or level 2 as long as they're feeding fine and they're safe, all the way through till we get them on a cup. But everybody with the new marketing and everything, they think, oh, well, you did 1, now we have to go to 2, now we have to go to 3. And sometimes when you have a little kiddo that's a little bit older, 9 months are up and you take them into a daycare, they want them to feed faster, and faster is not better when it comes to feeding. You have to keep them safe. And so sometimes you have to be an advocate for all of that. So the flow rate, cross cut, X cut versus a Y cut. The Dr. Brown nipple has a silicone nipple that's a Y cut. And the nice thing about that is every time you suck on it, you get the same hole size. When you have a cross cut, sometimes if you squish it, you get a bigger hole versus if you do the plus sign on it. And so you have to watch that for making sure they're tolerating it and not choking. And anytime liquid is coming out of a child's mouth, the nipple is too fast and we have to figure out how to slow it down. So we can thicken it, we can pace them, we can change the nipple. And those are the 3 main things that you look at when you are working with bottle feeding with a kiddo. Sometimes families have been taught, or some people have been taught, if you squeeze on the cheeks, the problem when you do that is that it actually changes how you suck and coordinate with the breathing with that. So that's not necessarily something that we recommend. And then some people will put fingers and thumbs under the jaw and under the tongue to push the tongue up. And that also, it can change how you suck, swallow, breathe. And you have to be careful when you do compensatory strategies with that. The most important thing is that the tongue has to shape around the nipple. And it has to be able to reach and pull and work with that. So if it's a big hole and you can't get the tongue around it, then you have a bigger risk for them choking and having troubles with that. So next slide. There you go. This is the tongue cupping one. So with the large hole, the tongue can't surround it well enough and get it going. There you go. Thank you very much. Okay. So a lot of people prop bottles with babies. I do not ever recommend that. I know what happens, but babies should be held when they're feeding. So you want to keep them as upright as possible, and sometimes sideline. We can get sideline to help out sometimes because then it's not shooting straightly back and gravity's not pushing it back down their throat, increasing their risk for choking. I talked about swaddling with them. There's all kinds of nice little blankets that people have, or little onesie things that you zip in and they swaddle with that. So swaddling is important, but we also have to know how to pull that back because you don't want them totally swaddled all the way through, 9-10 months of age. They need to be able to start relaxing, and you can pull it down under their armpits so they can maybe have a little bit of hands and get the midline with their hands and working with that. But those are all important things. It's important to have a good feeder seat to sit upright with low tone, especially with our kiddos with low tone, because you want one that maintains the head. You saw that tumble form that we had for the swallow study. There are other forms like Fisher Price. There are nice ones that kind of elevate the whole body when you do that, and tilt the back together with the hip. Some just pull the back, and then you end up leaning too far back, and that's not the best way because you increase your risk because gravity can make you choke on that. But you want to be able to kind of where you have your hips are at a 90, your knees are at 90, and your feet are flat when you're working on feeding with them, when they're sitting up in a chair and doing that. We already talked about the thickened liquids on here, but just so that you know, honey thick is a consistency that we can use. You just have to be careful of keeping them hydrated. So what is that telling me?
10 minutes.
I have 10 minutes left?
No question.
Okay, all right. All right, semi-foods, we'll go through here just so you guys can have the information here. So typically the birth to 13 months is breast or bottle feeding. I have not mentioned breastfeeding. Some kids can breastfeed. A lot of kids with low tone cannot get the full feeding out. So you might need to pump the supplement and work with that. But just so that you know, that is a possibility. This just aren't always usually as efficient as we want with that. Thin baby foods, those are the stage ones, or cereal. Sometimes we'll start with cereal and breast milk and formula, mix that in between 4 and 6 months. Stage 2 baby foods at 6 months. However, if they've been made totally MPO and they can only have thickened stuff, we might do puree starting around 3 or 4 months. That's stage 2, like I told you with that. The puffs you can add in. People will sometimes survive on these. These really are just a short-term oral motor practice. With that, we should be transitioning over to mashed table foods between 8 and 9 months. And like I said, the other texture, soft table and mechanical foods. All right, semi-solid foods. Next slide here. This, like I said, is usually between 4 to 6 months, or about 13 to 15 pounds. It's typically formula and cereal, and that's what we start with. So sometimes with kids, if they can have like 15 ml from a bottle, but they aren't taking the bottle, we might take that 15 ml and mix it with cereal, or a baby food puree, and start offering with that, because the idea is for them to like it and want to hold them. It's not nutritionally important right now, other than we do watch the calories, but it's an important thing to put in to the practice with that. The next slide is transitioning between that 4 to 6 months, where you start getting true sucking on a bottle, and how well the tongue is moving up and down and taking it back. The rooting reflex starts to fade, you know, when you tap on them and they turn to it, and they actually get more purposeful with their sucking and swallowing and taking stuff off of the spoon. They might start gagging with new textures. That could be a problem with this. An open mouth, you want them to have their open mouth when they come up to you. Lip control is important. An up-down motion of kind of a munching is what you see. And that they can, that they're cooing and making some sounds. Not all of our kids are doing that, but, and that they have good breast support. Always is about respiratory. We've had a little kiddo that I've worked with who, we would get the okay to do stuff, and then boom, he was sick, you know, with a pneumonia or those kind of respiratory issues. And it took us a while. He's good now and he eats very well. However, you just have to be careful, because sometimes we have to make sure that they're healthy overrides everything and build up with that. So I put a list on here of just some basic low carb fruits and vegetables, kind of asking kind of a down. I know there's all kinds of diet opinions with what we're doing, but the main thing is that we would look at some of these that we can use, like green beans are lower, broccoli is something we can use. So things that you may not always find in baby food form, but we can take regular food if we need to and cook it down and get it ready with that. And low carb fruits to start with. And berries, because these are all good and they're all important. They're all nutritional. We just have to make sure that we're not filling up on too many calories that aren't going to help us with our kiddo, to keep them healthy and to maintain the right protein level and doing all of that. So when you're starting solids, you want to have the kid be interested in it and working with that. We start out in the beginning with just 1 to 2 feedings. Like I said, it's not a nutritionally important thing. It's just an oral motor practice thing. And 1 to 2 tablespoons. If you get 5 bites in a little baby, it's actually a very good thing. Usually they take only about a tablespoon. A full jar of baby food is not a feeding. It's actually probably about 6 to 8 feedings. And people don't realize that. They think like a full jar is a feeding time. At this stage, they do not need any juice or water. They're getting their fluids from their formula or breast milk if they're taking that. We don't want to add any extra stuff like Caro syrup or honey. Sometimes people think that that's a way of thickening stuff and adding it so that they might take their food. Like if they've been refusing, they make it a little bit sweeter, they might take it. Formula does not taste as sweet as breast milk. So sometimes that, but it's not recommended to do that. Any Caro syrup and honey, they're at risk for botulism actually under a year of age. And babies should be held for liquids when they're taking their bottle, or up in seats for when they're taking food. I put a fun thing on here about the rainbow of all the colors. So you need to, I always say you need to teach your child to eat better than what you do. So all kinds of fruits and vegetables. So even though if you don't eat them, you still want to make sure that your baby gets used to them. There's all kinds of fun. These are silicone. There's just some people who have free time. I did not have free time to make all the baby food, but that's, some people have time for that. And these are fun ways of doing it. Then you can mix it up and add it in. Typically you want your child, then we're ready for semi-solid foods, which would be the puffs, and working with mashed soft table foods with that. You want them sitting a little bit upright. You want them to see how they hold objects and work with that. 5 minutes. And then you start food one at a time also, because you want to make sure that no one is having a reaction to it or working with that. The other new thing is that lot of doctors or the American Academy of Pediatrics has recommended adding peanut butter in earlier rather than later now. And I would talk to your pediatrician about it, but if you have that, then that's something that we can work with that. But I always say wait and do it at your doctor's office when you want to try it. So that way, if there's a problem, that way you're right there. There we go. Feeding the baby. Babies typically prefer sweet. Breast milk is sweet, and salty foods, and they may reject some of the bitter foods. And we don't need to add stuff to the bottle. A lot of times people just put a bunch of stuff in the bottle, all the purees in the bottle, and they need to actually develop oral motor skills with a spoon and working with that. 10 exposures may be needed to establish a new food. So if you get 6 or 8 bites in a little kiddo and you do that a couple times a day, that's how you can teach and so make sure they're tolerating it. Sometimes our little kiddos that haven't had food exposure or have a hard time, it takes more than that. Up to 30 times sometimes, but it's okay. You just have to be calm and persistent. You don't give it the bite the first time and say, oh, they don't like it, and think that they'll never eat carrots again. You just have to teach them. They don't have to love carrots, but they just have to learn how to eat them. So, and parents' eating habits influence that too. You want to teach them to eat better is what I always say. Spoon feeding is important. They need to be as upright so you can work on oral motor stuff. So that way they're not, gravity is increasing the risk for choking on that. Baby spoons are important. The flat ones are better. Metal or plastic, to me, I don't really worry about that. But you want to make sure have the baby open their mouth. I rest a spoon on the upper gum or the lip. And we teach them to put their lips around the spoon and suck on it. And that's a very important thing. You just don't want to put the food in their mouth, put the food in the mouth, put the food in the mouth and wait them to do that. They aren't getting exercise out of that or oral motor practice with that. You really need to have them work with the spoon and do that. Clinical eyedroppers are sometimes what we use for little kiddos if they have a hard time with that, because you can place it in the left and right sides of the mouth and we can work on that. So if our kiddos that we're extra careful with because of swallowing or aspiration issues, we can work with that as we need to. Don't ever force it. You don't want to swipe it all over their face and with the spoon. You don't want to scrape it off their mouth. You don't want to press down on the tongue. Pressing down the tongue will trigger your gag, and if a baby gags enough, they will vomit. And I'm not a big fan of mixing everything in so that you can't tell what it is. I think you should teach vegetables and then teach your squash and then teach your peaches or whatever, and make sure that you teach them the different flavors with that. 6 to 9 months category here. They should be taking most of their purees from the spoon, handling thicker and lumpier foods, and some self-feeding. They might be trying to hold the spoon and grab the spoon and taking that. And by here, you should start working with the cup. Again, I showed you that straw cup that I use, but that's the one I like to work on them, that they start learning to suck on that and drinking from there. If they can't suck from a straw, that means they probably aren't very good with the spoon, and the spoon is what we start with for oral motor practice. Again, serving size is 1 to 2 teaspoons. Again, so that's not even a full tablespoon of 2 to 3 purees. Some people start with vegetables. That's typically what we do with our little kiddos here. And fruits are important to teach them because they will be able to eat those as well. We just want to make sure that we balance it out. We also kind of get to the point where we add a protein. So that might be where we have a baby food dinner with meat in it, or we can add meat to some of the purees that we have. And then a fruit or vegetable, and then the puffs that we use in the multiples. And you should also make sure, again, that you put it down in a spoon. If you always feed out of the container, sometimes kids will get picky and they only want certain things out of certain jars or the little plastic containers, and they know if you're not doing that. And again, a new food every 3 to 4 days. So healthy fats that we add in, there's organic coconut oil, all different kinds of olive oils that we can do. They recommend that you rotate it around. There's the proteins that we have. Cream cheese, avocados. I love avocados. I start this as a first food with most of our kids because it's a good healthy fat. And really after 8 months, all you need to do is add a teaspoon up to a tablespoon of this into some of our purees, and we can make something that isn't very healthy, not very healthy. That doesn't have any calories to make it be healthier with the fat that we need for the babies. Proper soup. Again, proper portion size. A jar of baby food is not it. That is 6 to 8 servings for a baby. And they should get maybe 1 to 2 tablespoons at a year of 2 to 3 different foods. And that's really the volume of it. They can have more, but for calorie wise and working with that, we watch out for that. I have a picture here of the cups that I like. The blue there, the green straw, that's a weighted straw. And sometimes we transition that, but I almost always start out with our Rubbermaid Letterless cup here. I actually order them off of Amazon. You used to be able to find them a little bit easier. but they're only $4 or $5 each, and that's where we work with that. So, all right, 6 to 9 months oral motor. We're going to go fast here with that so we can have time for questions here. By this time, the adult is still doing most of the feeding. The baby should be picking up maybe a couple things. They should be sipping from a straw and working with that, and they should be getting stronger with their drinking from the straw cup and using different foods, thicker purees with that. They don't have to be as runny with the little kiddos. The puffs we can add in here. Like I said, I usually start with a veggie stick typically. We work where they bite and crunch on the side, and they work with that. And then safe bite-sized pieces. A safe bite-sized piece for anybody is the size of your pinky fingertip. So this is my safe bite-sized piece. Yours is the size of yours. A child's is the size of theirs, so it's much smaller. So we have to be careful with the sizes, the size of bites that we give the kiddos, because we want to get it in their mouth. We want to put it in the left and right side of their cheeks, not right on the tongue, because if it's on the tongue, it can make them gag. And then we develop tongue lateralization when we're working on that, and they're crunching and chewing, and that's how they work with that. 9 to 12 months, a variety of foods, the cup as your diet advances. Depending on where they are and growing, sometimes we start putting a little bit of the milk, whole milk if we can, into like an ounce at a time, so they start getting used to that. Or a lot of times these kids will start having yogurt by now, so we're getting some of the dairy in with them, and how they're tolerating that. Okay, there we are. There we go. Okay. That bottom's another soft, chewy texture of some of the food. So sometimes we can get peanut butter in with this and the coconut oil, and we can work with that, and we can make this. This can be a nice, soft, chewy texture. We can do small pieces with that so that they can get into that. And then you can freeze them, pull them out. And these are easy ways for kind of that keto, high calorie with the healthy fats, and working on mixing in other foods with them for that texture. 9 to 12 months, we transition over to table foods. You should be on some mashed soft table foods with this. So it might be that you take like some of the cauliflowered rice that they might have with that. They might have some pasta. There's different pastas made now with beans and quinoa, those kind of foods that we would take and mix in, let them work on chewing and biting and eating with these. And so a kid should be picking up and working on self-feeding, and then we help supplement. So it's called co-feeding, where the baby takes part of it, the meal, and then the parent takes part of it. Helps give the baby part of it. 12 to 15 months, biting and chewing, because we start having more teeth in the mouth. That all helps us out. They should be drinking from the cup independently and weaning off of a bottle. Usually I like them to be off of the bottle between 12, at the latest 12 months, or earliest 12 months, latest 15 months, because that's an oral motor skill that they will keep sucking on all the food, and that increases their risk for choking. So we have to be careful with that. And this is when toddlers start becoming toddlers. So with the foods, we want to start working on their 3 meals, 2 to 3 snacks. You don't want them to graze through the day. I always recommend that they're sitting in a chair, because that's the best way to control their oral motor, especially if you have low tone. Sometimes these kids aren't pulling up yet or moving very well at this time, so we still keeping them as safe as possible sitting up and working with the wide variety of healthy foods. Milk can, so usually depending on where their weight is, if they're tube feeding, sometimes the doctors will have you and the nurses will have you go from a formula over to something like a Pediasure or something. That's not the best choice calorie wise for our kiddos. So we usually try the whole milk and work with that. So that's really what our best bet is. But we do have to follow what the doctors recommend with that. But we do use regular milk. And so usually between 12 and 15 months, if your weight is okay, then you transition over to whole milk, because you're eating a variety of foods. If you're not eating a variety of foods and working with that, then you can't be on whole milk by itself, because there's not enough nutritional value in it. Cup of drinking, straw, munching patterns, self-feeding, holding their cup. Okay, here we go. 15 to 18 months, they should be totally off of a bottle by now. Practicing with their milk intake, usually about 16 ounces a day. Juices, if they're allowed, we usually don't do that. Usually water. I recommend water, and practicing with water with our kiddos with that. Snack times, again, it's usually 3 meals and 2 to 3 snacks, controlled snacks where they're doing that. You are on 12 to 15 months. Keep going. 12 months, there's the milk one. Keep going. 15 to 18 months. There we go. Okay. Alrighty. So we talked again about safe bite-sized pieces. If you want to give them meats and working with that, cheeses, small pieces, safe bite size. They should be feeding themselves at least a few bites still and working on that. Hopefully more than that. Drinking from a cup, and playing with their food. I don't mind if they're playing with their food and you can still work on them taking a bite or two, but you don't want them taking food and smashing it everywhere and not eating it. We have to make sure that they're still eating and liking it and going from there. All right, common food traps is that, so at a year, like I said, usually between 12 and 15 months, depending on where their weight is, your intake of formula drops down because you start getting calories from food and calories from your milk with that. So if you have that, then it should balance out. You don't still have to have, 6 to 8 ounces at every feeding time. Usually you have breakfast, which is 200 to 300 calories, and then maybe 100, 200 calories from your whole milk, and then with 4 to 6 ounces, and you do that. So again, it balances out. The doctor and the nutritionist will always give us a plan, and we work with those calories and those guidelines, but we still don't want them, we just don't want them to be stuck only taking formula or only getting a toddler formula and not calculating in the food calories with that. Let's see here. We don't need a full jar of baby food. We don't want the tongue. Is normal. It does not mean that big. Oh yeah. So it's normal for a little kiddo actually to spit stuff out, especially in the beginning when you're working on it, because they're used to pumping and sucking with their tongue. So it doesn't mean that they don't like it. Again, they don't have to like everything they eat. They just have to learn to eat a wide variety of food. So that's what you want to teach with them. And it takes lots of presentations. One time is not do it. And you want it to be fun and have new experiences. So that way you can go to a restaurant and have a plan and go out to different places. And it's hard because we have to know the different foods and the calories and build up from there, but that's what we get. Yep, the last 2 pages are just resources with that. All right, so I talk very fast. I apologize. Now I'm here. What do I need to know from here now? Any questions or any comments that people need?
Let me get my screen.
Okay,
Back again. So one question is, so my baby was put on NPO with no timeline, and our appointment isn't for another 6 weeks.
6 weeks. How old do we know how old the baby is?
No, I don't.
Okay. So knowing how old the baby is helps with that. If they're just still like that birth to 3 months, then you're probably okay. And I would maybe have a pacifier and dip it in with some stuff. So maybe they could get a little bit of taste with that, but not getting too much from there. If they're a little bit older, then we still might be able to try just a little bit. Were the NPO off of a swallow study, I'm guessing? Yeah. So it might be that you could ask the doctor if we could do 5 or 10 ml practice with that and practice that for a couple of weeks, because again, that's a long time to go without anything by mouth at all. And we don't want them to be so aversive that they won't try it later on. So I would ask if they could do a little bit, maybe once or twice a day. And if he still says no, then at the next time when they go in, I would say we definitely need something to practice with. We can't just say NPO for another undetermined amount of time because we'll lose our skills. And we're teaching the whole time we're working with them is we're doing physical therapy to teach motor planning and to help them so they can be ready with that. So it's the same with eating in the oral motor with the mouth, and it will help them with speech down the road if they are getting practice in doing that.
Okay. Another question is, if you don't have a speech therapist at the moment, what's the best way to practice oral motor?
So it would depend on how old the child is. So if
for
it's
an infant.
Yes. Okay. So if it's an infant under 6 months, potentially, then you could use a pacifier and work on that, because that was fine. You could dip it in the breast milk or formula so that they get a little bit of taste. When you have a pacifier in the mouth, you kind of hold it up toward the upper gum. So that way the jaw is soft, but it can still come up, and we can work on them getting some sucking practice and working with that. The other thing is that if not, you could, if they're a little bit older with that and you want a little bit of practice, you might just put some little baby food flavor on their fingers, and they might suck on their fingers, or you could tap a little bit on their lip and they might practice a little bit of sucking on that. There's no real true oral motor exercise of, moving your tongue left and right 10 times or doing tongue clicks 10 times or something. There's none of that backs up with any research on doing that to a kiddo. It has to be kind of a natural thing where they practice with a little bit of taste and flavor while they're still safe and working on that. So.
Okay. The next question is, what are the portion sizes for 18 months?
Okay, so at a year, it is 1 to 2 tablespoons of 3 to 4 different foods. And then by 18 months, it is anywhere from 3 to 4 tablespoons of 2 to 3 different foods. So, so again, if they're hungry and they want a little bit more at one time and they eat less the next time, nobody actually eats. The tube-fed babies get 120 ml, 6 times a day and working with that, but people don't really eat that way. People to eat more at one time, or they're better at breakfast time, or they are inconsistent with that. So, but in general, if you put down, so 4 tablespoons is 2 ounces. So if you put down 2 ounces of 3 different things, so you're at 6 ounces there, your protein, your vegetable, and all that. And then again, if they want more, they can have a little bit more. We just have to make sure that we're still within the calorie guidelines of what they're recommending for us.
Here's another question. How would you make the decision to go from, if your infant is on an NG tube, to a G tube? I know a lot of parents who want to avoid that, but at what point does it make sense to move to a G tube?
So typically you can stay on an NG tube if the child is not pulling it out. You can stay on it up to a year. Actually, NG tubes are really recommended for about 6 weeks. That's typically what they're recommended. In the infant population, they're used longer because if the baby's not pulling it out, or they can keep it taped and do that, then that's fine. And like I said, in my case, our daughter was vomiting. We had tons of reflux issues because of her low tone. And she was vomiting it up every day. So once it was every day and we were fighting to put it in, we as a family made the decision that it would be safer for her just to have a G tube, so that we weren't putting it in and going in and out all the time with that. So little kiddos typically don't really start pulling it out until about 9 to 10, 12 months of age, maybe. So if that's the point with that, where it's an issue, our kids sometimes still aspirate, sometimes the whole year while they're little, just because of low tone. But you can be on thickened liquids by mouth and not necessarily need a tube with that. If you have a swallow study, and you can teach the baby to get the volume up that they need. But it's really, so sometimes doctors, I think sometimes parents feel that doctors, and I don't mean all doctors, but I mean that some doctors push for a G tube quicker, getting it off the face. I have some kiddos that I've seen that have lots of rashes and reactions from tape on their face, or they're also on oxygen. So it makes it hard to keep all the wires and everything taped onto their face. And so sometimes just getting it off to give the skin a break is also important to help with that. So, but if the little one has it in and he's not pulling it out and everything is fine, then you can use an NG for as long as that's still happening with that. The baby's still safe with that. It's when they're pulling it out a lot, or it's getting pulled out a lot. I also had a family that the sibling, the little kiddo, had just an older sibling, not a lot, like a 2-year-old with a baby, and they would pull it out accidentally playing, trying to take care of the baby, and they realized that it wasn't safe having that happen either. So there's not one set answer for that, is what I would say.
Yeah, that's fair. The next question is my 20-month. Okay, I'm going to read this, and I think I understand what it's saying. My 21-month son doesn't leave bottle for milk feeding. Does it have any negative effect? Also, he is underbiting. So is that a result of the bottle, and how to avoid it? I think what they're saying is their 21-month-year-old child is still using a bottle for feeding. Does that have a negative effect? And he is underbiting. Is that a result of the bottle?
Well, I don't know if the underbiting is necessarily a bite. I don't think the bottle necessarily causes underbite. I think that just might be true an anatomical kind of thing. I would say, without knowing all of the history in general, if someone asked me if a 21-month-old was still on the bottle, would I recommend that? I would say no. So we need oral motor practice with that. The problem is that when you get older with that, your suck actually does get stronger, and you're at more risk for choking because you're still in a bottle, because it goes straight in and it shoots straight back to the back of your throat. So I would say that if you were to walk in my office today, I would say, okay, this is the cup we're going to use. The Rubbermaid straw cup is what I would recommend. I would probably thicken it in the beginning just to get a little bit of so it's not too fast on the kiddo, and then start working on them where they can actually tuck their chin a little bit and suck on that. The reason I use those is because you can give a little bit of a squeeze on those cups and get that started to help them get the idea of sucking. If he can suck, if he's 20 months old and he can still suck on a bottle, he can learn to suck on a straw cup. And we want a free-for-all straw cup, which means that he's not fighting the suction off of the device that's in there. So I would start practicing with something with that, and then just start transitioning so that so you can wean off the bottle and get more cup practice with that.
Great. We have had a few people who have mentioned with COVID, it's been difficult to have sessions, therapy sessions that are in person. Are there resources that could be helpful that you know of that would help a parent to, I guess, with oral motor exercises at home?
Mm-hmm. Yeah, it has been hard. So this has been an unprecedented time, is what I would say, in the sense of working with some kids and doing that. And I've had just some kids that do okay, like with teletherapy sessions, and the whole, it's actually a family thing. It has to be the whole family that can work through it. And other kids that it's just been too hard and we can't get it to work and organize all of that. Off the top of my head, I do not know if there's a basic resource other than the American Speech and Hearing. ASHA might have videos that I don't know about. But other resource, I mean, if they just need to talk to somebody, potentially that might help out. And the early intervention is what I would say. So early intervention potentially is something we have it here in Indiana. We're all back in the homes with everybody right now. So
Yeah.
yeah, and they mandated that. I mean, you can still do teletherapy. You just have to have lots of documentation and logic behind it to help out with that. So I do not have a good answer for that question. I apologize.
That's okay.
Mm-hmm.
We can always, if you think of something, I can always provide that.
And, you
with
know,
the video.
if you really have questions, I mean, they can always email me and I can kind of get more information. If I can see more information about it, you know, what it is. So, because to me, oral motor is working with food and working with a spoon and working with that. So it really just might be that we practice with them eating with a spoon and holding it the right way. They might need to practice with, you know, the veggie straws or something like some of the hip peas kind of thing where they hold it to the side and work on that. So we can develop oral motor with food issues. And we just need to see where they are with that and work with that. But just kind of basic, you know, blowing on a straw 10 times, that's not going to do anything that helps them. There's no research that backs that up. So,
Yeah. Okay, so the last question is more about nutrition. What's the best way to teach yourself about nutrition for our kiddos if the nutritionists don't have the best?
you know, Sarah, it's all still kind of fly by the seat of your pants. We do
Yeah.
get information. I mean, there's a diet that, so Dr. Miller's, most of the kids that I see have worked with Dr. Miller down in Florida, and there's a dietitian who helps with that, or that team helps with that. So they have those kind of guidelines. It's kind of that, you know, it's kind of a Mediterranean keto combination kind of a thing. There's not a real full set plan with that. We work with lower carbs. We do more vegetables. So we still do fruits and vegetables. We just try to find the healthier foods with that. There's a lot of resources. I know you guys have the parent sites, you know, the Ladybug or whatever, and the other one. So if I actually have questions, I call some of the moms that I know and say, okay, this is what I have a question about, and they can help me out with it. But it is hard to find it all out. I would say the doctor should help you with medical stuff. If you're not getting the kind of information that you think is helping you and your child, then just keep asking, because you know, you're, as you said in the video there, you're your child's advocate. You have to ask 100 times. It is not okay. We had one little baby that we worked with forever. We had no idea that he had Prader-Willi. I had none whatsoever. And he was gaining, and the dietitian was harping on the mom. And it was like, why is this such a problem? We couldn't figure it out, you know. And then finally, when it all happened, we're like, well, duh, now we know, you know. So a lot of medical teams, they mean well, but they don't always appreciate or understand the difficulty with our diagnosis here, Prader-Willi, and how to keep up with it. So just keep asking questions, because there are people that are good at it. It's hard to find them sometimes. Just hard to find.
Yeah, I will say we do have resources on our
on your site. Yep.
YouTube page. So on our YouTube page, we have videos from past conferences specifically with nutritionists, and they identify a lot of different diet recommendations, nutritional information. Michael Tan, he is with Dr. Miller. He's put out some great information that we've shared in the Facebook groups that are on the bug groups is what we call them. But if anyone has questions about that specifically, you're welcome to reach out to me and I can forward that information to you, or you could go to YouTube and look up FPWR and see the past conferences that we've had nutritionists. There's a lot of information there.
There are, and a lot of times the families just really truly have a list written down of all the foods and they keep it in their on their fridge or on their kitchen cabinet. And that's what they have and that's what they buy. And but you want to get savvy because you can also do some stuff at Starbucks, you know, you just have to know how to think about it and how to do that. And you can go to restaurants, you just have to think of how to order stuff and have it around. So